Good afternoon. We are really excited to do this introduction session to capacity. As you know, you've signed up for this quality improvement program, which is going to start in January 7th, 2020. We have 32 teams across Ontario. A quarter of them are nurse practitioner led. It covers 12 of 14 LINs, and we have 175 providers in all those teams. And so, as you can see, as you're scrolling through all the people on the sides, we've turned everybody's cameras off, but there's people from all over Ontario. It's super exciting to meet the early adopters and innovators. Today's session is really just to get us off to a good start, to know what you signed up for and make sure you're prepared once we start class, so to speak. Oh, okay. Well, you saw me waving, but that's me. I am one of 18 other members of a research team who are a mix of academic researchers like myself. We have nurses, we have family physicians, specialist palliative care doctors, and caregivers, all of us who put together this work and of course, informed by many of you for many years. I wanted to introduce you to your capacity facilitators, Maggie, Daryl, and Kayla, who you might be getting emails from. These are your facilitators for the whole project from beginning to end and your main point of contact. And of course, the team has other specialists, experts. You have local mentors and a primary care network. So this is the whole team supporting you to try to make you as successful as we can be. We've set up today's session as the top, well, as a 10 questions or 10 frequently asked questions. But as we're talking, and if you do have questions, type them into the chat box. We might have time at the end to respond to them on the webinar, or we will collect them and respond to either in a mass email or directly to you, okay? So without further ado, I'm gonna start with the first question. At the very beginning, what is the problem capacity is designed to solve? And why are we targeting primary care providers? This won't be new to you, but palliative care is mostly delivered in hospitals. It happens very close to death. And, well, providers, but many patients and families want more and earlier access to home-based palliative care. But we all know there are not enough specialists to provide palliative care at home. And that means there's more pressure on primary care providers for basically everything, but including palliative care. And there might be, we do get this question a lot, but I know some people feel like palliative care is part of their primary care identity. Some people feel like, well, there are specialists in this. What is my role in palliative care? So there's a very nice review article that came out just this year that was, what are the essential attributes for a non-specialist, or i.e. primary care doing palliative care? And it covered these domains: pain and symptom management, communication, patient and family education about the illness trajectory, prognosis, and goals of care, and physiological and spiritual care, which is, you know, each of these bullets are big umbrellas of things. So basically, the take home here is there is a very large role for primary care in doing this work. And part of what we're going to talk about and help you to actualize is, what does that mean for your practice? When we say this huge umbrella, there are barriers, right? People often tell us they lack knowledge, the skills, the tools, the resources, and the support. One of the solutions to addressing some of those barriers is the standardized education program like Pallium's LEAP program that many of you have already taken. And we've heard for many years, people wish that there was a LEAP, 2.0, which is really the next step, right? After the clinical, there's a lot of emphasis on clinical, not only, but mainly on clinical skills. They wanted simple tips to operationalize what does an early palliative care approach look like in their practice? And what are the practical strategies that I can embed into my everyday work? That is what capacity is designed to do. Okay, so that's what's the problem. And this is an important question. Question 2, what is the difference between end-of-life care, palliative care, and a palliative care approach? Okay. End-of-life care is defined by the period right before death, such as the days or weeks before death. That's pretty straightforward. Palliative care, however, is an approach to care. It's a philosophy. And it's focused on improving the quality of life for patients and families facing serious illness, which includes pain and symptom management, all those like psychological, social, and spiritual issues. And the key as an approach to care is that it can be applied early in the course of the illness, and it can happen concurrently with life-prolonging therapies. So it is not a label, it's not a diagnosis, it's not a point in time. A patient is not a palliative patient. They could benefit from a palliative approach to care. And so with this new philosophy, this approach to care, and to try to change the emphasis from just the clinical, physiological aspects of what palliative care encompasses, we've tried to say a palliative approach to care, because it's often misunderstood as end of life. You know, so a palliative approach to care and palliative care for this project are the same thing. We're probably just going to simplify it and just use palliative care, but we really mean the approach. And this whole question, this whole little 3-minute spiel is to underscore that when I'm talking about an early palliative care approach, I'm not talking only about end-of-life care, because we know that's implemented very close to death. When people think about even just palliative care in Ontario or across Canada, globally actually, it's implemented very close to death and only after this curative care has been exhausted. So an example, a stage 4 cancer patient without any complex symptoms could still benefit from receiving a palliative approach to care. And so part of our job, my job and the team's job, is to help you be like, what does that mean to me in primary care at my practice? Like, what things could I do early on? But the key is to separate the palliative approach to care from end-of-life care only, and it requires a philosophical change. And that the benefit of that is you're not a grim reaper when you talk about palliative care. We're not giving up hope. It's about adding support to the care plan, adding support to your patients and families. Okay, question 3. What are the biggest barriers to doing what I just talked about? And what's the solution, which is capacity? And I'll explain what that is. So the biggest barriers that we've heard time and time again, and these should be no surprise to you, are people say, well, I don't have any confidence in my skills. No time, it's more work, there's no money, I don't see the value, and I don't have any support in my clinic and support by my team. And these are all legitimate barriers. So the confidence and skills, many of you have taken LEAP already, the standardized education or some equivalent, EPIC, ECORE, to build some confidence. But that was the clinical confidence. And all these other pieces have not fallen into place to allow you to really feel confident and embed early palliative care into your practice. So capacity really focuses on working differently, not more, having more easy and practical things. So it actually allows you to feel like you're doing less work or different work, that you're compensated for your time. And people tell us they have an increase in job satisfaction because they have the best practical tips and they have built a strong team. So how do we do that? Through capacity. Okay. Capacity is capitalized because it's an acronym, which if you want to get grant funding, you have to have a cool acronym. So it took me years to come up with this one, but capacity stands for Community Access to Palliative Care via Interprofessional Teams Intervention. Too much of a mouthful, we just call it capacity because the goal is to build capacity. But I'm pretty sure that acronym helped us get funded. Okay, what is capacity? Capacity is a 1-year quality improvement program, and it uses 10 steps to operationalize an early palliative approach within primary care. Okay, the goal is to help you build your ability to deliver palliative care to more patients and earlier. And it is not designed to just find a way to identify patients and automatically refer you to specialists. Of course, that doesn't mean you never refer to specialists or palliative care specialists. It just means that's not the #1 default, okay? Instead, it's focusing on simple practical tips and strategies to help you operationalize this. And we've got this curriculum from years of those co-investigators that I showed you on the first screen. They've been doing pilot projects prospectively in all these little pilot projects across Canada, and we've put it together into this virtual format so we could scale up. And we've heard from not just the researchers, but also the people who continue to do it daily. And there are examples of how do they do this successfully. Okay, this is our visual the 10 steps that you're going to go through starting January. We take the summer off. And, you know, step by step, we're going to walk you through what you need to do. And at each session, each month, we hope there's a goal, you know, one take-home message or a few nuggets of information. I'm going to call them gold nuggets to help you get over the hump and to help you take action, to do one thing, to, you know, a baby step that you feel, yes, I could do that. And that's going to allow you to build the confidence bit by bit. So that by the end, you'll have the, you know, the basic skills to start doing this. So we have one session per month and a 30-day challenge. So that's really the gist of Capacity. Simple tips, and we've curated the tips. We've got the best speakers coming to you from across Canada, and the best advice. So we're cutting through, you know, all the reports to give you just the take-home messages. Okay, this is a very, very important slide. What's the benefit to you who's listening in your phones, in your offices, in your, you know, your meeting rooms? And I like to call it the WIFM, the what's in it for me, the WIIFM. Every session will have a slide up at the front that's like, what's in it for you to do this, okay? So what's the benefit of Capacity overall? The best practice tips. So we ask them specifically, what are the tips and advice from the 20 years that you've been doing this that you're gonna tell people, and you have 10 minutes. They summarize the strategies and practices that you can implement. Not just the tools, not just the reports, but the practical strategies, the everyday tips. You're going to have mentorship and support by experts, the research team, and others. At the end of Capacity, actually, our very first session is about building team collaboration. So it's not doing it alone. It's about who's going to help me to do this, and how do I build our confidence and collaboration so that, you know, we can do this together. Lots of people means less work, right? Okay. People tell us the benefit is they have increased confidence in doing the work. They've increased job satisfaction because they feel like they're giving better care. They have better communication. They have a better understanding of what does it mean to have a palliative care approach. They feel empowered to do this. And this is why they got into primary care in the first place. Here's a big offer that we're suggesting to you, your CME Main Pro Plus credits. We are in the process of getting certified for 3 Main Pro credits per webinar. It's a very comprehensive package. I've never seen a more comprehensive package. So in a month, that should be confirmed. We'll resubmit to make sure we get 3. And then with the 30-day challenge, and you're doing some self-reflection and writing that up in a linking learning document, you can submit that to the college and get an additional 5 CME Main Pro credits. So that's 8 per session, there's 10 sessions, 80 for the whole program. So in that year, you would have earned 80 credits. And even if you're not a provider that submits to Main Pro, you know, watching the webinars, doing the reflection exercises is still gonna help you to, you know, change your practice. Okay, there's no fee to join the intervention and be a part other than your time to do the work, which is not inconsequential. And another big offering is right at the beginning, we talk about optimized billing advice. So there is a video tutorial developed by Dr. Bob Sauls, who's going to speak right after this, in like a minute, where he created a billing webinar specific to primary care. So that's he built it from scratch. It's the only one. There are other billing webinars out there, but they're too general. This is specific to primary care. Okay. So that's what's in it for you guys. This is question 5. How is this connected to other provincial initiatives? And this is an important question because we don't want this to be just work that's off the side of your desk, right? There has to be thinking about sustainability from the start. And so our primary knowledge user partner is the Ontario Palliative Care Network. I'm going to turn it over to Dr. Bob Sauls right now. He is the provincial clinical code lead for the Ontario Palliative Care Network. And we have been working closely to recruit you, but also to make sure Capacity aligns with provincial initiatives, regional initiatives, so that this is not just off the side of your desk, and when the funding and support ends, this will just disappear. We want it to be embedded in your everyday work. So we asked Bob to speak to how this connects with OPCN's work and how it's connected.
Great. Thanks very much, Cian. You can hear me okay?
Yep, we hear you great.
Great. Thanks very much. And I have to say it's exciting to be participating in this launch of Capacity, and really excited to hear that all of you are participating. Maybe if you go to the next slide for me, Cian. The Untitled Palliative Care Network was formed about three and a half years ago, and is funded by the Ministry of Health. Our goals, and this is a broad provincially based network, and our goals are to be the primary advisor to the ministry on issues related to palliative care. But maybe even more importantly, is our goal is to work towards improving access and quality of palliative care across the whole province. One of the ways that we're seeking to do that is by producing tools and resources to help those both planning and developing palliative care services, but also frontline clinicians in terms of how they deliver care. And what I'm going to do is just briefly outline some of those resources today. So if you go to the next slide, probably the starting point was a piece of work that was a collaboration between the Ontario Palliative Care Network and Health Quality Ontario, which was published now about a year and a half ago, which is called the Palliative Care Quality Standard. And what this describes is 13 quality statements that really tell us what high quality palliative care would look like from the perspective of a patient and their family. And it focuses on care regardless of what setting people are in. So it is things like identifying people early, making sure they have a holistic assessment, making sure they're receiving their care from a team, making sure that we have good quality conversations with them. It also describes how we should measure that, so it describes some proposed indicators. What it doesn't quite do is say, how do we do these things? So that's actually the next step. And if you go to the next slide. For example, the first quality statement says, and it's actually written right there, that's the statement of the first quality standard. And that's about identifying people earlier. And so as Cian said, this is very much an important goal, is that we identify people who might benefit from palliative care much earlier in the course of their illness. And we know there's good research evidence to show that if we do that, people actually have better outcomes. But the question is how to do that. What this document that we published now in April of this year does is it outlines the tools that we might use, and these are very practical tools, validated tools that will help us to actually do that. And you're going to learn more about these in the subsequent webinars, but for example, there are probably within this 2 tools that some of you may have seen that are particularly helpful within primary care practice and are actually quite practical to use to help us start that process of identifying those people in your practice who would benefit from this. The document also does point to some extent to some of the tools you might use to actually go on and do a further assessment of those patients. And again, something you'll learn about in subsequent webinars. So Cian, maybe go to the next slide. So the next piece of work is really, and it's called the Palliative Care Health Services Delivery Framework, or what we now refer to as the Delivery Framework, which really describes how we should go about delivering care overall. What's the process? This really highlights the importance of care being delivered by an interdisciplinary team. And some years ago, Cian published work that showed very clearly that patients and families who receive care from a team have better outcomes than those who don't. Sometimes there can be some confusion about what we mean by a team. So with this diagram that you see here, what we're talking about is the team that any individual patient and family see. And that team would consist of, at the very least, a core team, which is a physician or nurse practitioner, someone who's coordinating that care, and in many instances, a nurse. Particularly if the patient is at home and receiving care at home, that's going to often involve a community nurse. If the patient is early in the course of that illness, that team maybe resides solely within your practice. Patient may be well enough to come to the office. As patients' needs become higher or more extensive, that we're often going to involve other providers, and that might be PSWs or dietitians or rehabilitation folks like OT and PT or social work. And again, that team will vary from one patient to the next. And finally, every team needs to have access to palliative care specialists. These are often nurse practitioners, physicians, nurses, who are expert in palliative care and can provide support by either mentorship, what we call just-in-time access, or direct consultation and care. We're distinguishing, let me go back to this, distinguishing this from each of you now participating is part of a broader team, which are a group of providers who are providing care to a population of patients. And so we sometimes talk about team in two different ways. If you go to the next slide now, Cian. This is what we call our patient pathway from the framework, which just describes sort of the flow of care. And although it's linear, it won't always be linear. But as you can see, there's that early part of identification and assessment, followed by the formation of the team, getting coordination going, identifying the team, and then this iterative process of ongoing assessments of needs, having discussions about goals and developing a care plan, and then finally moving on at some point to end-of-life care and bereavement. And again, you're going to learn all about these various phases through the course of this program. Okay, go on to the next. One of the other resources we have is about those discussions. So, you know, you hear lots about advanced care planning, which is pertinent for anyone, regardless of where they are or whether they have any illness at all. What we're talking about here is for those patients who have an illness where there need to be some discussions about the nature of their illness and prognosis and about decisions and treatment decisions. These are a set of resources, which again, you're going to talk much more about this. These resources are there to support and help guide you through those discussions with patients and their families. And the next one. And finally, what we've also done and published this April was what's called a competency framework. And in other words, for everyone who takes care of patients with palliative care needs, we all need to be competent to do that. And what we've done with this framework is look at 15 different professions, including volunteers, and describe what each of those professionals or clinicians needs to know, either at what we would call a generalist or a primary care level, and at a specialist level. So what this document would have, and for you to peruse, is to look at what's described for your particular discipline as to what things you need to be knowledgeable about and comfortable with providing in terms of the competencies you need to do this work. Much of it you will have learned in LEAP, or if you've taken LEAP or other courses, there may be additional things that you're going to learn through the course of this webinar. And I think those are the key things I want to outline. As I say, you're going to learn more about all of these issues as the webinar series goes on. And I think I'm happy to take any questions. I could obviously respond to the chat if you have any questions about these. Thanks very much for letting me participate.
Thanks very much, Bob. Yeah, so I think it's exciting to partner with the Ontario Palliative Care Network, not only because there are, the resources that they've put together and made available online and sort of done some of the heavy lifting with the evidence, but also because, there's a clear provincial support at this. We have at the provincial level, there's each region has a regional director. There's 2 clinical co-leads. I suspect many of you, most of you know these folks, but from our perspective, they're not only there because they have an inway into, the funding, the policy, the direction, but they have the local intelligence and your local concerns, your regional concerns, or context for us to adapt what we're telling you into your level. So we clearly recognize there's not a one-size-fits-all. We're trying to give you tips and practical advice that can be applied anywhere, but there will still very likely be things that are specific to your community that we're going to have to work through together. And that's how we have local facilitators and monthly calls, et cetera. I think the other key piece of having the support with the Ontario Palliative Care Network is so that this isn't just, the flavor of the month. There will be a clear plan, multi-year plan that has, support from all political parties. And lastly, going to this framework, this delivery framework. So this is the document that all, when we had LINs, they were all signed on upon, and this is what we are trying to move at a system level change. And so capacity is very much at the bedside, at the front line, but it's helpful to know when you're sort of changing practice and working so hard that there's support at the mid-level and at the system level. And so this framework was a huge piece of work that Bob and others led to do that. And capacity really does address all of the boxes, just not in a left to right framework. So in each of our sessions, in the appendix on the last few slides, you will see which session does this address, and we'll go into that. Okay, so there is clear alignment. Oh, and the other really important thing is that the Ontario Palliative Care Network also has their own evaluation and has a survey that they are going to be sending out in the next couple of weeks that they're hoping that you can complete. So we have a survey, I'll talk about that you want to complete that's going to evaluate capacity. This is for the Ontario Palliative Care Network. So that is also going to be coming your way, and to please complete that. Okay. So moving on, we are at the halfway mark and we're at our halfway question. So great timing here. Question 6, what do we mean by team? So Bob just talked about how the Ontario Palliative Care Network has different definitions for a team, and we say team and teamwork. Okay, this is our simplest way to try to describe what the heck we're talking about. There's a QI study team. That is the people that signed up to join capacity. So capacity is the quality improvement. I guess QI is only 2 syllables, capacity is 4, so we call it QI study team. But these are the people who are, in the boardroom that you're sitting around. These are the people who committed to joining the webinars, okay? That's the heart of this. There is an inner team. These are the people, your colleagues in your family health team or your community health center that you interact with, that you work with closely, but may not be signing up to join capacity or to say, I want to do something different or not right now, or didn't take LEAP training or whatever. So these are critical people in your inner team, your inner organization, but are not in the QI study team. And then we talk about a broader team. These are people in your community, in your neighborhood, like, the pharmacists or the social workers or the Meals on Wheels, all these different people in the broader community who are involved, depending on the patient, in connecting to palliative care, but you may not see on a day-to-day basis, okay? Capacity obviously is very focused on the QI study team and changing actions, behaviors, the practice of that team. You're gonna need the help of the other 2 circles. To support you, you have a local mentor who you've been paired up with. You have the capacity facilitators, Maggie, Daryl, Kayla, the capacity research team led by me, and there's 18 other people, and then the primary care network, which are a volunteer group of people working in primary care. So your peers who agreed by email to answer specific questions when there are context or community specific challenges. Okay, so this is what we mean by team. We're mostly always talking about the QI study team. I hope that's clear. So I talked about the local mentor who you're going to be paired up with. What is their role? And we will communicate this with them, or when they signed up, this is what we told them, but we're also telling you. The local mentor is a palliative care specialist with advanced training, such as a fellowship, 2-year fellowship, and an experience in palliative care in the community, in the home. They're an information resource for your team. You can contact them for advice in caring for a patient requiring complex care or has complex needs, or even just say, hey, how should I approach this? They're your phone a friend, so to speak. One of the keys that we wanted to emphasize is, being a mentor doesn't mean they're required to provide 24/7 support to you or to anybody. They may do that, and if they offer that and want to include you in their list, great, but that wasn't a requirement. And frankly, it's not a requirement for you to provide 24/7 support either, okay? So you should discuss this and negotiate this or before you get started. And they are not expected to provide direct care to all your patients. So where it's appropriate, our goal with Capacity is hope that you can remain the most responsible provider, particularly for patients with basic needs, basic palliative care needs. When they become more complex, this is where you can connect with your specialist to figure out, what should the role in negotiation be. But some people thought this was just like a direct, easy way to send their patients to a specialist. And okay, that's not the goal. Okay, so that's the role of the mentor. If there are questions about that, type them in the chat box. Okay, what data are we collecting? This is question 8, okay? This is a quality improvement project. It's focused on action, but it's also a research project. So the data we're collecting, our outcomes are here. We're primarily looking to see, do you identify more patients as requiring a palliative care approach? We're going to use self-report for that. So we've asked you before, or we'll ask you again, how many patients in the last 6 months would you say you're giving palliative care to? And at the end, and we hope that sort of broadens. We also want them to be seen earlier, and we'll collect that in a different way. We believe that this process, this virtual quality improvement program, will increase collaboration, your social network density, your trust amongst your team, and your confidence. So we have validated tools that we're going to measure before and after. We also believe that, we hope very strongly, that these sessions are going to help you change your practice in small ways, and lots of small changes can add up to big change. So this is where that linking learning evaluation, where you reflect on the 30-day exercise, which you submit for CME credit, we will be collecting that to see how well we're doing in each session. Can we make them better? And, are these activities helpful? And at the end, we'll also do some qualitative interviews. We have the benefit of, having an integrated healthcare system. So we will be linking to billing data, physician billing data, to look at how you billed before, during, and after the program. Where did people that your patients and your roster died, and were you seeing them earlier? Were you identifying them earlier before death? So we're going to use admin data for that. But you should know the data will never reported the rate will always be reported in an anonymized way. So we won't be identifying your team name or any individual physician or clinician or team. We do not collect any patient data. It is only your self-reported data. And then this data collection is a requirement of this, because we have to know how we're doing. It's part of our funding, but we promise that it will not be onerous. So the survey that we're going to send you, I think the longest one is 10 minutes for clinicians. I think it's 5 minutes or 2 minutes if you're the team lead or as another provider in the team. So the data collection is simple. It's not meant to be onerous for you, because we want you to focus on providing care. We're going to take care of the data part. And you should also know we do have ethics approval from McMaster University to do this. And this project is funded by the Canadian Institutes for Health Research, CIHR. Okay, question 9, we're almost there. What is the format of capacity? How does this work? Okay. I'm going to give you, we tried to organize today kind of like a session, not the frequent 10 questions, but just sort of, that we will have Zoom, the first few minutes we'll see each other, then we'll jump into slides, okay? So there's an introduction in the first few minutes. There will be a recap of what you did, how did that activity go? And then we're going to jump into what is the focus of today, what's the next building step, and you're going to hear back-to-back talks from 2 experts, 2 short sort of TED Talks, so to speak. One is from a resident expert, a palliative care specialist expert typically, but not necessarily in that content area. They're going to summarize the evidence and tools for you. They're going to give you the best advice from having done this for, 20 years on average. The best advice for you from the expert's point of view. Then you're going to hear from a peer, another primary care provider, such as yourself, nurses, clinicians, others, who are going to offer their practical tips of how they incorporated this topic into their practice. And we end with a 30-day challenge. So in the next, for the rest of the month, we'll give you either 1 thing or 2 things to choose from to do. And we will leave you time, maybe 10, 15 minutes, to talk as a team on how, you can do this. The 30-day challenges are not boiling the ocean. They're simple things that came from the talks and should give you the steps 1 or 2 to get you to the thing. At the end of the session, so after the 30-day challenge, you may not yet know how your team is going to connect, if you're all in the same room, or you're going to have a separate conference number or another Zoom license, which is free. So you guys can, press another button and it'll take you to another webinar. However you guys want to do it, or it makes sense. But we hope that you can either send us your questions that came up from that discussion right away, or within the next, by day 12. Any questions that you have from your meetings, send to us, because that's what we're going to respond to. We will send it to our experts and this National Primary Care Network, who has been where you're at and can answer your specific questions. So that's customized help for you. We will, day 15, there will be a phone call with your team lead, with the facilitator, to check on things. We will send you back those answers, hopefully within a week, so it'll be day 19 or so. And we hope by the end of the month, say day 29, you'll complete your linking learning as best you can and submit to us. And if it's still in progress, submit to us and say still in progress, and I'm going to submit the full thing next month, but we want to see where you're at. So that's really the format. We do this, 10 times over a year. Each step builds on the next. And we purposely broke it up into these, so to speak, baby steps, or these small activities, so that to avoid all the costs of bringing everyone together into one place for 2 days or twice, 1 day over 2 times, because that's very impractical, expensive, not feasible, and you leave with you're supposed to do 80 things. This, hopefully you have the motivation, the idea, the nugget, the gold nugget here, to do the one thing, that 30-day challenge. Okay, so that's how it works. And question 10, what are we expecting of you? Okay, this is where I'll spend a little bit of time. What are we asking of you? What did you sign up for? So first of all, it's a team effort. Teamwork makes the dream work, right? Someone who is a dance mom told me that. So she made me put that in the slide. But okay, so our hope in an ideal world, we don't live in an ideal world, but in an ideal world, the team members all attend these 10 monthly webinars, okay? Ideally, you're together at least at the same time, wherever you are in your car, whatever, or in the same room, because then you can look at each other and go, oh, that makes sense, or that totally is not going to work, or we need to do this to make that work. We recognize that, it's a clinical practice. You can't always be in the same room. These will always be recorded. They will be posted online. But it's kind of like, it's like, I'm trying to think of an analogy, but if you watch sports and you tape the game, how often do you really watch the game after? It's not the same thing as watching it live together. It's like the Olympics, watching with your family. It's like, oh, it's so exciting when it's live and a lot happens in real time. If you watch it sort of after, it kind of doesn't have the same excitement. And that excitement is critical to getting you over the hump to take action. That's really what this is all about. It's not about leaving with the best tools. It's about how do I use those tools in a simple way so I can make a difference at the bedside. Okay. In your team, the office administrator, your main office assistant, is very critical. So to the extent that they can join, they're absolutely welcome. As you know, the Zoom license is open. You can send it broadly. Anyone you think is relevant can join. But they're a key member. And another key thing that we offer is that we will make sure we leave aside 10 to 15 minutes in that 1 hour lunch break to talk with your team. Of like, they asked us to do this. How, what is reasonable? What can we do? How do we adapt that to our setting? Okay, that 10 minutes of planning makes all the difference. Not to wait 2 weeks to do that 10 minutes of planning. Okay, so work as a team, try to attend these, at least listen to them live or the same day, and then meet shortly after to, make the plan on the day of or so, and start working towards that. The 30-day challenges are obviously a key part of this curriculum. You do them as a team. So that means you probably will need to find a way to meet or chat by email or, WhatsApp group chat or something to just figure out who's going to do what and keep the momentum going. Maybe once a week for 20 minutes would be sufficient. And so scheduling those regular meetings now is going to help you. Like find a standing time potentially, and decide on the way you're going to do that, whether that's Zoom or a teleconference number. There's Adobe, there's Slack, there's many different ways to do that, whatever works for your team. And if you're not sure, our facilitators can give you some suggestions. And then who's going to help you keep you guys accountable? So that's key. What we're asking of you, ask us questions, email us anytime. Your facilitators are there, that's their job. Probably by the middle of the month, any questions you have about how you can do the 30-day challenge, that's what we want to know, so we can get advice from real people, from real-time experts to respond to your specific question. That customized advice is critical. The facilitator is going to collate those questions, send it to this primary care network, provide you an answer, right? And we will find an efficient way to send out the responses or the key questions of what people said. Either a brief email with 10 questions and then, or specific to your team directly. And then the evaluation. So completing those surveys, there's only a few at the beginning and the end. The linking learning forms, ideally they're done within 30 days. Maybe occasionally it'll be 60 days that your team will work on it. But that not only is useful for you for your CME credits, but useful for us to evaluate if we're doing a good job, how it helped you to change your practice, what could we be doing better? And then, at the end, we will select some people and teams to talk in qualitative interviews. Okay, so the evaluation piece is key to us, obviously. And here's, well, as I was saying, at the end of each of these webinars, there will be a challenge, a 30-day challenge. So because we have 3 months between now and January 7th when we start, we have a 30, 60, and 90-day challenge, okay? The 30-day challenge is you're going to get an email from us, probably this week, that has a link to our evaluation surveys. And if it's different, it has skip patterns. So if you're the team lead, you have slightly different questions than maybe if you're a clinician, but no longer than 10 minutes, the whole thing. So we hope that you can complete those surveys within 30 days, by the end of this month. We hope that you can book a standing meeting with your team and decide on how you're going to communicate. Our 30-day challenge, my teams, is we're going to send you save the dates for the 10 webinars, and we're going to send you the link for those surveys, in the next couple of days. And also, as I sort of mentioned, that's why it says and OPCN survey, you will be getting a separate email from OPCN to complete a survey for them. I also think it's decently short. It's a different ask, but it's a provincial ask. It's important to connect what we're doing here with the provincial stuff, so please respond to that too. Any questions about the OPCN's survey, direct to them. That's why we're having 2 separate emails, so it's not confusing. That's really the 30-day challenge. The 60-day challenge really applies only to physicians. I told you Dr. Bob Sauls, who who spoke to you today, he created this from scratch. It's a billing module. It's a video. It's maybe half an hour. It tells you specific to primary care about how to bill for all the different situations. He worked with the Ontario College to make sure all the information was accurate. It can be found on the website. The website for this project is my website, palliativecareinnovation.com/building is, and the link is there, is where our webinars will be posted, and that billing webinar is there. You can watch it as many times as you want, but probably only need to watch it once. But it addresses the question of, this is different work or more work in some situations. Am I going to be compensated for it? The answer is yes. And this is, and so knowing that is going to be important. And the 90-day challenge is particularly for the clinicians, so nurses, physicians, meet with your mentor. So we're going to send the link. Our 30-day challenge is also to send you a link to your mentor, introduce you to the groups and your mentor virtually. But by the end of the year, we hope you'll have met with them for lunch or coffee or a phone call to discuss what are your expectations, who are we, how are we going to communicate. And if you have never done a home visit before, if you've never done a home visit, it's a good opportunity. It's highly, highly, highly encouraged to maybe do a joint visit or to talk with one of the members of your team who works in a home care worker to understand the value, because this work can't only be done in the clinic. It connects to people who provide care in the home. And even if you do this one home visit and don't do another one, you at least can appreciate what the people in the home are bringing to the table. Okay, so that's the challenges. The facilitators will definitely send you to this, but these seem like they're all small and achievable in 30, 60, and 90 days. I hope you'll agree. And so that's how we end most of our webinars, with this challenge. And there's always an appendix just for where the references. So I'm just flipping through the appendix, the references of where the evidence is based on. You can find these later. Like I said, Capacity was built on all these other published projects from across Canada doing this work, and now it's being scaled up. And in some ways, this is the new and improved modern version, and we've learned from all those previous mistakes. Now it's more streamlined. And these are a link to the Ontario Palliative Care Network's, OPCN's website and the delivery framework. If this LEAP has this taking ownership module, it's free, and you probably already have done it, but it just goes back to what I talked about, is like, why do this? Palliative care is for everyone, the ABCs of palliative care. So that's something, if people are new to the project or newer to palliative care, they could, it's free, and I think it's 30 minutes as well. So I'm gonna stop sharing. We have 11 minutes. I'm wondering, I'm going to ask Kayla if there are some questions that have come up on the chat that I can answer. But otherwise, now is a good time to type in any questions that you have.
Hi, CN, it's Kayla. I just wanted to show the teams the Palliative Care Innovation website. You do have to type in your name and email. I'm just going to share my screen so you can see that, how it looks. Okay, so here's the website. This is palliativecareinnovation.com/building. When you do go to this site, you'll see a little bit of information about Capacity. As you scroll down, because you are already a participant, you can fill out your name. So I'll put in my name and my email address. And then when you click Submit, you'll go to a page, and that includes the billing module, as well as you'll get the recording of the webinars. This would be a good page to bookmark on one of your computers, so that you'll be able to come back and get some of the session materials. We'll be posting some additional materials, some of the linking learning pages on here throughout the webinars.
Great, thanks, Kayla. So yeah, typically we would collate the questions and get proper answers from experts, get a couple of eyeballs on the question and then send you an answer. Today we have about 10 minutes. That was all the, the formal stuff. So the first Tuesday of every month starting January. So that's January 7th. Fortunately, it's not the 2nd. January 7th, 2020 will be our first session 1, where we have our first, real content and that CME accredited. And that's when the real work will begin. So today was really an introduction session to get you set up, get, make sure all the technology works, answer those kinds of questions.
Hi, Cian. Daryl is just going to answer some questions that we've come up in the chat box. So Daryl, you should be good to talk.
Perfect.
Hi, Cian. So we did have a number of questions about the measures that seemed to raise a lot of interest. So I don't know if you want to speak to that now. We are going to send out an email in a couple days explaining that further.
Yeah, perfect. So yes, so our primary measure is your self-reported data of how many people in your roster, how many people, because again, your QI study team is not necessarily your entire family health team or your entire inner team. So of the providers who have patients, how many, what is your caseload, and how many that you would identify as having a palliative care approach, like that you've been delivering palliative care to, and how that's changed from the before, during, and after the program. Okay, that's our primary measure, your self-reported data. This means that if you do not bill, or shadow bill, or you're a nurse practitioner and don't bill in the same way, you can still participate, and that is our primary measure. Self-report obviously has a bit of a bias, so you might sort of up your numbers when it's time to report because you feel like, whatever, there's a bias there. So we have a secondary sort of another look using ICES data, the Institute for Clinical Evaluative Sciences, where we will look at the billings, and again, it will be only limited to the physicians who are in the program, unfortunately, whether you're in a family health team or a CHC. I understand physicians bill differently in those different programs. We will note what kind of funding model you're in and recognize that might explain some of the changes. But the goal really is practice change, right? I mean, we want more people to be identified earlier on. And did this help you to operationalize things? So those are why all the tools are there. And this is why the linking, learning, and qualitative pieces and any emails that you feel about this was valuable, this wasn't, is going to be useful for us. That's the most important thing, is to change the experience for yourselves and your patients and families that you serve. Okay, so if there aren't new questions, we will send out an email with the link to the survey data. We will send out on the website, there'll be some data about measurement. Yeah, and we can sign off. I think we will be in touch by email, and we look forward to working with all of you. And the 30, 60, 90-day challenges will come out to your team leads and to all of you. So thank you very much for joining, and we'll be in touch by email, and see you in the new year where the real work begins. And hope it's gonna be fun. I hope, I promise. I promise it will be simple advice. It will be evidence-based. It will be all the tips and strategies that are useful. That's our promise to you. And yeah, working together across the province, I think is gonna be fun. So thanks. I'm gonna sign off. You get 5 more minutes for your lunch. Okay, take care, everyone.